Living Lecture Series. Again, this is the Summer Sessions and a Foundation Health Partner effort. I'm Mike Powers. I'll be introducing tonight's speaker. As a reminder, these lectures are really part of Michelle Bartlett's vision and efforts, and they have evolved over the years. I was talking to a neighbor who has kids, 11, 13, 15. I said, well, what are the kids doing this summer? And he said, they're kind of sitting around not doing much. I happen to have one of these in the house. I gave it to him, and I said, let's just look at this. I think I counted 67 different camps. Alaska Wildlife Camp, Aviation Camp, Botany Camp, cooking camps.
Where do I sign up?
Exactly. And that's not even into the adult camps yet. But dinosaur camp, drone camp, cool concepts in calculus camp, going ballistic with physics camp, golf camp, house heroes. Do you know your house well? What's inside? Where does electricity come from? How can you keep a building warm in the winter? On and on and on. But if you have grandkids or any neighbors, etc., send them through these Ollie sessions. It's just amazing. It's award-winning in my opinion. But anyway, tomorrow night we have Discover Alaska lecture, Vice Chancellor Charlene Stern, A Changing Landscape, Community Development in Alaska. Thursday night, Music in the Garden. 6 p.m. is Ryan Bowers and Brain Trust, 4-piece acoustic ensemble, folk and Americana. 7:30, Almost Dominion, very good klezmer ensemble. Both groups very active. You've heard their names many times, I'm sure, in Fairbanks. And just a reminder, all this goes back to this partnership between the university and the hospital, made very active recently with Michelle. And it was 50 years ago that many university folks helped out, took lead positions with building the foundation and then establishing an award-winning, highly recognized community hospital and long-term care facility. So with that, let me introduce tonight's Healthy Living speaker, Dr. Sriharsha Gowtham, or he goes by Harsha. Board-certified physician practicing with FHP Internal Medicine and Senior Care Clinic, and we have Dr. Mike Swenson right here, who is part of that esteemed group. Dr. Gowtham's focus on patient's perspective relative to symptoms of the body. Considered as much a teacher as a healer. Graduate of State University of New York, Upstate Medical University, simply SUNY Upstate. And its mission is education, biomed research, and patient care. He served both his internship and residency at SUNY Upstate. Board certified by the American Board of Internal Medicine, affiliated with the American Medical Association. And tonight, of course, is part of a 1-2 deliberate effort to partner with last week's health talk by cardiologist Dr. Ramel Wren, also heart-related. And Dr. Gowtham's talk tonight is entitled Heart Attacks and Aging, Know the Signs, Protect Your Life. So with that, I'm delighted to this over to Dr. Gowtham.
Okay. Can you guys hear me? Awesome. Oh, thank you. So I guess we can pull up the first slide whenever. So there's a very specific reason I chose this topic, and my hope is to give a series of topics on a wide variety of issues, medical issues. But I always start with chest pain, and specifically going into a little bit more detail about heart attacks in the heart. And the reason why I think this is so important is I had an experience once when I was a resident, and I came home after a long day's work, and my dad called me and he said, Harsha, I think I'm having some chest pain. And I said, Dad, what's going on? And then I asked him a bunch of questions, which I'll tell you guys about, everything I asked him and working through it. And I said, Dad, I think you're about to have a heart attack, or you're having a heart attack, and you should go to the emergency room immediately. And he said, it's fine. It's 10 o'clock. They're going to keep me overnight. And then they're probably going to tell me to go home, or they're just not going to do anything. Every time you say chest pain, you automatically go to the hospital. And I was like, Dad, you really got to go. I really think that this is serious. And he didn't listen. So I called my sister, and my older sister, and she's a pediatrician. I called her, and told her what's going on. And she immediately called him, and he says, okay, fine, I'll go. And then he nearly ended up with a heart attack, very close, within it was starting to just peak, so we got it just in time, and he's totally fine. But that told me two things, right? So this man, is the father of 2 doctors, and he had no idea what a heart attack feels like, He has no idea what was going on. And to me, that's embarrassing, right? As a son, that he didn't know that. And I think it is, it tells us that the system is not doing a good job educating our patients, right? The healthcare system is not doing a good job educating our patients about what to look out for. The second really bad thing about this is my sister being a pediatrician, he listened to her, not me. I'm internal medicine, I've seen a lot of heart attacks, but he listened to her because she's older. So I'm the baby of the family, so of course, nobody's gonna listen to me, right? So my parents are not. So so that's why I picked this topic. My hope is, I can talk about a lot of different issues, but I'm gonna try to focus a little bit on this. And my hope at the end of this is you guys are armed with a bunch of knowledge so that you can look out for symptoms for yourselves, look out for symptoms in your family and friends and in the community, people who aren't here, So this knowledge, I hope, will lead to helping many people, not just you guys. Yeah. So, okay, let's just start with the first slide here. So, first of all, so let's just say, you're coming in, somebody's coming into my office and then they have chest pain, okay? So my job as a provider is to sort of think about the differential of the symptom, right? I gotta go through the list of possible things that it could be, and my differential, which means that I come up with this list, which I prioritize some diagnoses, and I think other diagnoses are less likely. And I do that through a series of questions. But every single question I'm asking, it's not a waste. Every single question I'm asking is going to help me differentiate between the different diagnoses. Okay, every single question is going to tell me, is this part of the body, or is this that part of the body? Is this disease that's happening? Is it that disease that's happening? So, in the office, you get peppered with a lot of questions, and we don't explain why. So today I'm going to explain why, okay? So the first thing when you have a differential is to think about the anatomy of the area that we're talking about, right? So chest pain, right? So we're talking about pain in the chest, right? So before we go any further, don't click any buttons because you're going to get the differential. What do you guys think would be part of our differential? It doesn't have to be high priority or low priority, but what would you guys think would be important organs, we're talking about anatomy here, to consider when we're talking about chest pain? Heart, lungs. So stomach, so that's an interesting one. So heart and lungs are right here, everybody knows that. The stomach is right here, on the left here, I should say. So on the left side, on your on your left side of your abdomen, okay? And it can sometimes push into your chest a little bit. Also, it curves around to the middle of your chest here. Okay, there's a little C shape that sort of curves around, and the esophagus comes up into your chest. So that's another organ that can cause chest pain. Okay, anything else? More anatomy. What's there? You got the easy stuff. So think about. So pancreas is over here. It's right again in the abdomen, in the middle, right above the navel, in the middle here. So yes, that can sometimes go into the chest, but not so much. Anything else? Liver is on the right side, and gallbladder is on the right side. Again, it's unlikely to go right up into the chest here, but those are all really good things. The liver, though, I do want to make the point, the liver can sometimes be felt in the right shoulder, okay? Because there's a nerve that connects from your neck all the way down to the diaphragm above the liver. So a lot of times people have pain in the shoulder, and they have pain on the right side of their abdomen, where the liver and the gallbladder are, and that's how you know that it could be a liver or gallbladder issue. Okay. Any other organs? Bingo. So now we're talking about things that we don't normally think about, right? So blood vessels, okay? Large blood vessels like the aorta can all cause pain, okay? Anything else? Muscles, right? So we don't think about this very much, but one of the most common things people come in with when they're worried about chest pain is muscular pain, okay? And that's okay, and I'm gonna help you guys distinguish between those things today. But yeah, muscle pain. So spine is a little bit behind, it's less likely to be chest pain, but in the same way, bones, right? So the spine is made out of bones, so muscle and bones. Can you guys think about anything else? What else is on your like rib cage? Like what else is there? What's that? So breasts, yep, that's a really important thing for chest pain, differential.
Sometimes people mistake gas.
Yeah, so that's part of the esophagus. Gas is part of it, and that's part of the stomach esophagus that we talked about. Peritoneum is in your abdomen, so it's below here. Yeah, so not in the chest. So skin, right? So like think about like sometimes skin diseases. And there's this really interesting case. I was working in the hospital as a resident. This patient was like complaining of chest pain. He was there for like some other condition, I forgot. But he was like chest pain. And then immediately we were like, okay, let's do that EKG. My attending, I was a resident. Let's do that EKG. And then we did an EKG and everything was negative and he was still complaining of chest pain. And we were like, okay, let's do a CT scan. And we did a CT scan. CT scan was negative. We're like, what's going on? And we took off his gown and he had shingles. Okay, so this is the problem with doctors like rushing to tests and not really, we're in the hospital, right? We're rushing, right? Everything is a rush, right? In medicine. So, so skin is like an important part of the differential. So in other words, every time somebody comes in with chest pain, I better not forget about the shingles, right? Even though it's probably not likely to be shingles, I got to think about the entire differential every single time. So I will ask questions organ by organ by organ. There's one other thing, like nerve pain. There are nerves that go from your spine all the way across, your chest. That can also cause pain. So yeah, everything, all of the above, you just go layer by layer by layer, and then how to think about those in the differential. And every organ has some sign to it, some symptom to it, something about it that makes it unique. And we will be figuring out how to differentiate between all these different organs. Okay, so you can click through them and we can see some of the differentials that I was thinking about, So heart, lungs, esophagus, stomach. You guys got a lot of these. I like that you thought about breasts. I didn't put that in there, but that's like a really important concept for chest pain, which I missed here. So your blood vessels, and if you musculoskeletal, so your muscles, your bones, your ribs, nerves, so you got your nerves that go across from your spine, across your chest like this, they wrap around, skin. There's one other organ, psychogenic, okay, so psychological, okay? So don't forget your brain is also connected, so people who have panic attacks, things like that, they can also have chest pain, okay? So this is one last thing there, right. Okay. So before we do anything, I'm giving you guys knowledge. So I have to always come up with an asterisk and caveat to everything I say so that I don't, I don't get into legal trouble by giving you guys, I'm just joking. But the important thing is if it's an emergency, go to the emergency room, right? So how do you know it's an emergency? It's severe, the symptoms are severe pain, severe shortness of breath, sweating, sometimes a vital change. You might check your blood pressure and you might find that it's either really high or really low, or the heart rate's really high or really low. People know when something is an emergency, intuitively. And, it's something called the eyeball test that we do as providers. We walk in, we look at the person, if they're like, we're like, okay, go to the emergency room, right? So that's the eyeball test. So obviously if something is an emergency, they're sweating profusely, obviously go to the emergency room. But the point of this talk is to not let it get there, right? We want to figure this out before it turns to an emergency. Why? Because we're in Alaska, right? There are very few doctors, we're all busy, we're all stressed out, there's so many patients. The fewer emergencies that we see, the better for the system as a whole. Okay, so figuring stuff out early is really important. Okay, so let's go to the next slide. Okay, so like I said, every question that we ask is like a path, right? I'm standing at a path and I ask a question. If it's yes, I walk to the left. If it's no, I walk to the right to a different type of diagnosis. And this helps me narrow down what type of organs we're talking about. So let me start with something that's fairly easy to understand. So is it reproducible? Or is it worse with movement, let's say of your arm, right? So let's say that let's say I'm getting chest pain, okay? And it happens every time I move my left arm, okay? Is that likely to be your heart? No. Less likely, okay? The movement of your arm is kind of unrelated to your heart, except in one situation, which I'll tell you guys about. But the other thing is like, what if like every time I push here, it hurts. Ow, that hurts. Should I be worried about that? Not necessarily. It's less likely. I mean, maybe you should be worried, but it's not your heart, or less likely to be your heart, right? Why? Because there's a huge amount of bone and muscle and tissue that's like this thick between your hand pushing on the top of your chest and your heart being behind there. There's no way I'm pushing on your heart, right? When you're pushing on your chest, right? So a lot of times people come to me saying, I have chest pain, okay? And the first thing I do is I start pushing around. Ow. Okay, you're good. Do we need EKGs? Do we need all the stuff? Not necessarily. You know, I'm very confident that if that's the pain that you're getting, you know, then it's probably not a big deal. Okay, a couple of caveats to this. I had a guy who had chest pain. I was really convinced that he had heart issues. And I was like, okay, you need to see a cardiologist. And he went to the cardiologist. And the cardiologist did the full exam. And apparently he wrote in his note, pain is reproducible to touch, so unlikely to be cardiac, and sent him home. And I'm like, so I was like, this is weird. This is not how you describe the pain to me. I called the patient. This is not how you describe the pain to me. The cardiologist said you're having like muscle pain. He was like, yeah, I was having that too. But I'm like, okay, so this pain is different, right? And he was like, yeah, this pain is totally different from the pain he felt. So I'm like, okay, you need to go back to the cardiologist. So these subtleties are important, right? We're human beings, right? So we can have more than one type of pain at the same time. You can have more than one issue going on at the same time that are coincidental and layer on top of each other. So it's important to know the subtle differences and know that the pain that you're worried about is different from the muscle pain that you're feeling. Okay, so that's up to the patient to tell me that, right? Like I can't know like the different types of pain. But also it's up to me as a provider to ask that question as specifically as possible to make sure that I'm getting to the right cause. Okay, so if there's any issue, if there's any pain that's worse, that's reproducible, means like I can push and recreate the pain when I touch on the chest. Okay. Now, one other important thing about muscle pain is that the chest muscles are very broad, okay? And a lot of times people have a hard time pinpointing the pain on their chest. So I ask them, where do you think the pain is? And they say, it's right here. And I start pushing, we're chatting, and I go millimeter by millimeter. I'm making sure I'm not missing any, piece of tissue. I'm going as slowly as possible. We're chatting, how's your summer going, blah, blah, blah. And I keep going. And then by the time he says, ow, I'm all the way up here, okay? So it's hard to know, so you have to be careful, don't rush, okay? So if you're worried, if you think, okay, maybe this is just muscle pain, again, if you move a certain way and the pain comes, that's probably muscle, and then you can always confirm that by pushing on that muscle. Take your time, and then if it's musculoskeletal, you know how to rush to the emergency room necessarily, okay? Is it worse with breathing is the next question, okay? So in other words, if I take a breath and my pain gets worse, and then take a breath out and then my pain gets a little bit better. If it's related to breathing, it's gotta be either your lungs, I'm putting a little asterisk there, I'm not gonna go into detail about that asterisk, but for your sake, it's either gotta be the lungs, okay, or the muscles of the chest again. Right? Because you have muscles that help you expand your chest. So, let's say I injured my bicep, right? Let's say I injured my arm. Every time I move my arm up, ow, it's gonna hurt, right? So injured muscles, every time you use them, they hurt, right? So if I'm using the muscles of my chest by breathing, it might hurt. That could be related to muscle. It could also be related to lung, okay? Because the lung expands and that stretch can give pain. Is that more likely to be related to the heart? Where do you think the heart, how likely do you think the heart is?
Very. I think it's more likely than just the movement because your heart is kind of right by where you're looking at.
That's fair, but when you're breathing, it's less likely to be the heart, okay? Notice I'm saying likely, right? I never say anything definitively, okay? This is a differential. So I would put heart lower down on the list, okay? And I'll tell you guys the symptoms that we have with the heart. Again, the movement of the chest. The heart is sort of like insulated from that. Like it's sitting behind, in a certain specific area. It's sort of more or less insulated from that. You can have certain types of movement that are related to the heart, okay? This is, I'm not going to go into too much detail about it, but pericarditis, where if you lean forward versus leaning back, you're going to have more pain. But that's not necessarily what I'm talking about. I'm talking about breathing, So if you breathe and then you have pain, it's clearly related to the act of breathing, which is related to muscles or the lungs, okay? Is it variable with activity, okay? So in other words, let's say that you get chest pain when you walk, okay? And you don't get chest pain when you sit, versus you get chest pain when you sit and you don't get it when you walk, okay? So this is what I'm talking about. So how likely do you think it's the heart if you get chest pain when you sit, but you don't get it when you walk? Less likely, okay? It's more likely to be your heart if you get it with walking and it gets better with rest, okay? This is probably the most important point that I'm going to make today, okay? Heart-related pains tend to be, not all the time, again, this is all likelihoods, but tend to be worse with activity and better with rest. Okay, I'm going to go into detail about why that is later. But if it is worse with rest and better with activity, it's probably not your heart. It could still be. There are other reasons why it could be, but it's probably not related to at least heart attacks. Again, arrhythmias, for example, you can be at rest and have chest pain because the heart is just beating so fast because the rhythm of the heart is abnormal. But again, I'm talking here about heart attacks a little bit, so I'm trying to focus the conversation on that. Okay, so So again, if it's worse it's positional, like let's say you roll over in bed and it hurts, probably muscle. Again, if the chest pain is worse, depending on like if you're in front of dust or some sort of allergen or flowers or pollen or something like that, and that's when you're getting your chest pain. That's like because you're out, and you're getting it. Or sometimes people have asthmatic attacks when they're sitting, So it can happen at any time. So you can have chest pain. It can be your lungs or muscle. Okay. It can also be psychogenic. So in other words, people can get panic attacks and they're just sitting there. They're not doing anything. They're sitting and watching TV or something like that. So positional, right? So I spoke a little bit about this. It can be cardiac because of something called pericarditis, which I'm not going to get into. But it can also be the esophageal issue, and it can also be muscle issue, right? So if you lay back right after dinner, right, and you're sleeping, right, and you lay back, what happens? Acid starts going up because of gravity, right? If you stand up, acid is down. When you're going to bed, and you lay back, you can have acid going up. So that could be esophageal, gastric issues as well. And of course, musculoskeletal if you're like rolling around and it's hurting or something like that. If it's radiating the back, probably aorta, okay? Because the aorta is towards the back, so it's sort of like people feel this piercing pain going through the back. It's called a dissection. Again, not going into too much detail about this. I want to be focused on the heart. I'm just letting you know that this is, I ask questions like, is it radiating the back? Where is it? Is it worse with position? Is it worse with activity? I'm asking all these questions. I want you to know why. Associated with shortness of breath, it could be the lungs or it could be the heart. Why? Because both of them are important for movement of oxygenated blood, right? The heart pumps blood that's oxygenated and the lung oxygenates that blood, right? So if you're not getting that oxygen to your rest of your body's going to respond by trying to have you breathe so you can get that oxygen. If it's after food, it's probably esophageal or gastric. And if it's exertional, it could be heart, lungs, or muscle, right? So the heart is a muscle, right? So if you're using a lot of oxygen, then it could be the heart. And of course, lungs can also do that. Okay, so there are a bunch of questions here. I'm not going to go through all these questions, but I'm going to just try to focus on the heart and heart-related issues. But I want you to know this is how I'm thinking when you first come into my room. These are the questions I'm asking. Any questions about this? Makes sense, right? Your body is logical, right? Like in other words, if I'm not getting the answer, it means I'm not asking the right question. Okay? All right, next, please. Okay, now let's just talk cardiac, okay? So it is exertional in that your pain gets worse with activity and better with rest. Why? Because your heart is a muscle. So when you're active, when you're moving, your heart starts beating harder and pumping harder. So as a muscle, it needs more oxygen, more blood, and more nutrients in order to keep pumping. So then you will get more pain. I don't want to say you, a person would get more pain when they are active, and it will get better with rest. This is early heart disease, okay? This can progress to a heart attack, but early on, it's exertional, okay? When it becomes a heart attack, it is painful at rest, okay? So that's why this is important. And I'm going to tell you guys the anatomy of this later as to why it is exertional and gets worse and worse and worse. But the way I want you guys to think about it, it's like this person's hitting a wall, okay? So they used to be able to climb a flight of stairs without getting short of breath. Now they climb that flight of stairs, now they're getting short of breath. Now instead of 10 steps, they're able to take 8. Now they're getting short of breath at 8 steps. Now they're getting short of breath at 6 and 4 and 2. Now they're getting short of breath while sitting, and then comes the heart attack. Okay, the heart attack doesn't just come. There are weeks and months of these exertional symptoms that are probably ignored. You know, why are they ignored? Because they sit down and they're like, oh, okay, I feel better. I don't need to go to the doctor, right? So, but the point is that's exactly when to intervene, okay, before it's a heart attack. And recognizing those symptoms before the pain is happening at rest, when it might be too late and that heart attack is actually happening, and now it's time sensitive, now it's an emergency. You know, that is key, okay? My dad, he had exertional symptoms for weeks and probably months, but he didn't recognize it months ago. He just didn't think about it. He was probably having it and he was just like busy with life. So he wasn't thinking about it. He wasn't intuitive with his own body. And when it was happening, he's like, okay, it's getting better when I rest, so I think that's okay. I guess it's okay. I guess it's okay. And then he called me when it was happening almost continuously, okay? Okay, heart-related pain can also be, it can be like left-sided or central. You know, I've even seen some pains that are leaning towards the right side. Obviously, your heart is like sort of shaped like this. It's more pointing towards the left, so it's most likely on the left side. But I've seen it sort of all over the place. And it's predictable, right? So like I said, every time a person climbs that 10 steps, that chest pain starts. Okay, and if they climb 4 steps, there's not as much pain. Why is that? It's because there's a certain amount of blood that's coming to the heart, and the second the heart needs more blood, okay, and that amount of blood is fixed, right? You're not getting more. You're just getting the amount of blood that you're getting because of the size of the blood vessel, right? So if you need more and you're not getting it, the person's going to have pain, okay? So it's predictable, okay? This is different from people who haven't who have been sitting, it's wintertime, so they haven't really been exercising, and okay, it's summertime, so they start walking and they might start getting a little bit of shortness of breath or chest pain when they're walking. But that should get better as they get more conditioned, okay? So conditioning, when you're becoming more active and your heart is getting used to it, and your muscles are getting used to it, your lungs are getting used to it, you should be able to do more and more and more over time. When somebody who has heart disease, they do less and less and less over time. They cannot do more than their limit, okay? And the pain radiates to the arm, it can radiate to the neck, okay? Does anybody know why it radiates to the arms?
Nerve, the nerve system.
Okay.
Phrenic nerve?
So not the phrenic nerve. The phrenic nerve goes to the diaphragm. That's why you get the shoulder pain when you have liver issues. Anybody know why you get arm pain when you have when somebody has a heart attack? Okay, it's because it has to do with nerves, right? So the brain has a connection to the heart, okay? And it also has a connection to the rest of your body. But the heart is silent your whole life, okay? So the brain is not getting impulses from the heart from day to day, you know? Because the heart is silent because people aren't having heart attacks every day, right? So the brain is getting signals and impulses from things next to the nerves for the heart, like your arm. So when suddenly the heart wakes up and says, I'm having a heart attack, the brain doesn't recognize it because it's never heard anything from the heart before. So it thinks it's your arm, okay? So, and that's why people have arm pain when it's related to a heart attack, okay? Now I want to pause here. Well, let me keep going here. Actually, let me pause here. So I had this one patient. He was a window cleaner, and he was getting pain when he was cleaning the windows, okay? And then he would stop and the pain would go away, okay? And then he'd go back to cleaning the windows and he'd start getting pain and it would stop and the pain would go away, right? So what did we say? Like if it's related to movement, it's probably muscle, right? Is what we said, right? So that's what this guy thought, common sense, like it was happening with movement. So he thought it was probably my shoulder, maybe I hurt my shoulder. But it kept getting worse and worse. And eventually he was getting pain in his shoulder when he wasn't using his arm. And he went to the emergency room and it was a heart attack. So what was happening was when he was using his shoulder, his heart rate was going up. Okay, because his heart rate was going up, his heart is like, I need more blood, I need more blood. Wasn't getting it. It wasn't a heart attack yet. So it got better with rest. But because he couldn't recognize that sometimes you can have these symptoms that sort of coexist, he thought it was just an arm issue. So everything I say, there's a caveat to it. I've seen a case that proves it wrong, So again, these are all guidelines, you should always talk to your doctor if there's any issues. Okay, second, so it can mimic gastritis. That's why it's called heartburn, right? Acid reflux is called heartburn for a reason because they are very similar. Okay, however, heartburn gets better or worse with food, right? And if you take a Pepcid or if you take a Tums, it should get better, right? I had a patient who, when I was down in Seward, who was active, doing a bunch of stuff, and he was getting heartburn. And then he decided to take a nap and his pain went away. Luckily, his wife went to one of these talks, okay? I'm not kidding, okay? And she was like, it's getting better with activity and worse, better with rest and worse with activity. It felt like heartburn. He was like, no, this is heartburn. This is what heartburn feels like to me. She was like, take a Tums. It didn't get better. It got better with the rest. That doesn't make sense if it's gastric, right? It only makes sense if it's your heart. So she called me. I got him to the hospital. His artery was 90% blocked, okay? But he was fine because it wasn't 100%. So it was not a heart attack yet, okay? So his heart was totally fine, okay? Okay, so that's why what's important is, again, that worse with activity, better with rest. It can feel like a million different things. It can feel like your shoulder. It can feel like acid reflux. It can radiate to your neck. It can radiate to both arms. It can be a lot of different things. But it's usually, in the beginning, always worse with activity and better with rest. It can be associated with shortness of breath, like I said, because you're requiring more oxygen. And in people with diabetes and in women, there may not be any pain, or there may be these atypical symptoms that are not typical of chest pain. In diabetes, it's because the nerves are not working as well. I had a patient with really bad diabetes, and he was otherwise healthy, and every time he was active, his blood pressure would shoot up to 200, and we couldn't really figure out what's going on, right? He was not having any chest pain, no chest pain, okay? And I was like, you know what? I don't know what's going on here. There's no chest pain, but whatever it is, it's getting worse with activity and better with rest. Let me work up his heart, and he was severe. He had lots of bad heart disease, okay? So it wasn't typical, okay? It wasn't typical symptoms that he was having, no chest pain. I also had a patient in the hospital when I was a resident, who was having just nausea and vomiting. But the nausea, again, was getting worse with activity and better with rest. No chest pain at all. This lady was an older woman in her 80s or 90s, something like that. And my attending was like, something is just not right. Let's just do an EKG. And she was having an active heart attack, okay? Right? Close to active heart attack. So, okay. So any questions about that? Yes.
I think you covered it, but so the shortness of breath, I understand the pain, but you said the shortness of breath was more oxygen is being required, I guess, to oxygenate the heart.
Yes.
And then that has a shortness of breath relationship.
Yes. So people can have shortness of breath, or they can have chest pain, or they can have both. Okay, I'm just trying to let you guys know it can be a whole variety of symptoms associated with it.
I think you said something earlier, maybe, but where does significant sweating come in?
Yes, sweating is also one of these symptoms, and people can get it, again, worse with activity, better with rest. You can have it with pain or not with pain. So that gentleman I was talking about, blood pressure would shoot up and he would get very, very sweaty, okay? And would get better again when he rested a little bit.
Do we know why women present so differently?
I'm not sure we do. I'm not so sure. That's something I believe I asked before my attendings, and I believe they told me that we don't know.
They didn't do research
It could be the case. Yeah.
Yeah.
I haven't done enough research.
Yes.
So typically, you're talking about pain. What causes the pain? Is it what is typically causing the pain in the chest when you're having heart problems? What is creating that pain?
So any time organs are injured, they send a signal to the brain that they're injured. I don't know if you mean at that level or like at a more molecular level. It's like what is causing the injury? Is that what you're asking?
No. I just wondered, if you're saying that, then you're saying during a heart attack, or let's just say you don't have a heart attack,
Yeah.
but you're feeling these pains when you do exercise and rest. There's a pain occurring. The heart, I understand, is still not damaged, correct?
It is not, the thing is like, so when it's meeting that threshold where it's not getting, because your heart is beating so fast, you're not getting sufficient blood, that pain can be cardiac pain, you know? This can happen for anyone, right? Let's say like if I right now, a guy without heart disease because of, you know, age factors or whatever, if I run really, really hard to the point that my heart rate goes up to 200, I'm gonna have chest pain, and that is cardiac, you know, because I cross that threshold where my heart needs more blood than I'm giving it, okay? So, and that's a signal my heart is sending to the brain that I'm not getting enough oxygen. Either you need to stop doing what you're doing or you need to give me more oxygen, breathe harder and that kind of stuff, right? So that's why when we run, it's normal to sweat, it's normal to breathe harder, it's normal to have a little bit of chest pain when we're, you know, if you guys, you know, like exert yourself to like a significant extent, like running a mile or something like that, you know? Like it's a little bit normal to do that when you're crossing that threshold. You shouldn't be having it when you're sitting or walking, you know, like a few steps or something like that.
So it would be unusual probably, but then if you had one of those bone cancer kinds of things that are affecting your red blood cells that aren't
Exactly.
carrying enough oxygen,
Yeah.
you could have
Absolutely.
some concerns.
Absolutely. If somebody has anemia where they're not making enough blood, that same problem occurs. They're not getting enough blood to the heart. Okay, so I didn't include that in my differential, but that was under blood vessels. That's how I like to think about it, and when I think about anatomy. So it goes from, I mean, you start at the skin. This is what's interesting. When you have a differential, I'm starting at the skin and I'm ending up at the red blood cells. You see what I mean? I'm going all the way down, you know, in terms of depth, in terms of like microscope, you know, as deep as possible. And that's a fun part of medicine, okay? Okay, all right, let's move on to the next slide. Okay, so let's take a minute to talk about the different, because all these words get mixed up a lot when I talk to my patients. So there's a difference between heart disease, that's just a more or less colloquial term that we use for coronary artery disease. Coronary arteries are the arteries that feed blood and give nutrients and oxygen to the heart, okay? Just like every organ in your body needs blood to survive, the blood that is coming to the heart is called coronary artery, it's from the coronary arteries. So disease, which means plaque buildup, like fat buildup in the blood vessels, that we call disease. It's such a vague term. I hate the term that we use for it. Okay, but when we're talking about coronary artery disease or heart disease, we're specifically talking about plaque that is building up in the blood vessels to the heart. Okay, but there's also something called heart failure. Okay, and there's valve problems, valvular dysfunction, so valve problems, and arrhythmias, where the rhythm of the heart is not appropriate. Okay, and all of these things can cause similar symptoms. And one can end up causing the other. And we're going to try to differentiate between those things right now. Okay, and the way we're going to do that is to understand the anatomy of the heart. Okay, so if you could go on to the next slide, please. So the first thing to understand about the heart is, what is its job? What is the job of the heart? One job. What is the job? Circulation, it's a pump, right? Its job is a pump. Its job is to move blood in one direction, okay? So it moves it in a big loop, you know, and continuously pointing it in one direction. It gets oxygenated blood to the rest of the body. The body sends back deoxygenated blood because the body uses up that oxygen, sends it back to the heart, goes to the right side of the heart. The right side of the heart pumps it to the lungs. The lungs give it oxygen. That goes to the left side of the heart. The left side of the heart pumps it to the rest of the body, okay? The point is, it's a pump to get blood and oxygen and nutrients moving to the entire body. Okay, so can we go click on the first video, YouTube video, which will tell us how this works. Okay, can you click on that? So here, I don't know if you can like full screen. There's like stuff that are getting in the way here. I don't know if you can like full screen it or anything like that. Yeah, just hit that button there. That's square. Yeah, perfect. Okay, so what you can see here is the heart is this dynamic, moving muscle. Okay, and you can see what it's doing. This red that's shooting up through the heart, that's blood. Okay, so it's shooting blood to the rest of the body. It's not using that blood, okay? The job of the heart is to pump this blood to the rest of the body. That blood goes to the brain, to the kidneys, to the liver, and it gives oxygen and nutrients and things like that. So you can see it's squeezing. You can see the muscle squeezing to push that blood in that direction, okay? And the squeezing movement is actually, it's the same movement every time. So why doesn't the blood go backwards? Because of valves, okay? So valves are one-way valves in the heart. So they point like this, they open up, blood goes through, they close, they cannot close backwards, so blood does not go backwards, okay? So it shuts like this, it opens up when it's going this way, and when it's going backwards, they close so they cannot go backwards. So it is a one-way valve that moves the blood through, okay? You can see the valves moving, you can see the heart muscle pumping, and it's moving this blood to the rest of the body. It's not using that blood, okay? So the job of the heart initially is to pump. And if it fails at that job, it's called heart failure, okay? If it fails to pump properly for whatever reason, that's heart failure, okay? Notice that this is not necessarily anything to do with a heart attack or anything like that. This here has nothing to do with a heart attack, okay? So the way you got to think about it is like, let's say there's an oil tanker driving down the road, right? Let's say it's using some of that oil for its own purposes to help it drive, but most of that oil, it's transporting, it's not using it, okay? So the blood that's found in these vessels has nothing to do with a heart attack, but it has to do with heart failure. If this blood doesn't move from the chambers, it will start building up behind the heart. So think of like a kinked hose, and what happens? You get pressure build up behind the hose, and that pressure from all that fluid buildup results in heart failure and the symptoms of heart failure, which I'll talk about later. Okay, can we go to the next? Can we go back to my slide? Any questions about that? Because these are like kind of important concepts. I'm differentiating all these different things. Okay, second, let's just look a closer look at the heart valves in the second video here. So this is how your heart is normally supposed to work. These are all normal things that I'm pointing out right now, no diseases right now. So just very quickly here, you can see it's opening in one direction, okay? These are 4 different valves in the heart, and they're moving the blood in one direction, okay? So the blood comes down here and moves up there. Blood comes down here and moves up there. There's a right side deoxygenated blood, that's why it's blue on this diagram. This is the left side, it's gotten oxygen, so it's a little bit redder just for the diagram. Okay, in reality, blood is not blue, okay? But yeah, so okay, so that's how the valves work. Any questions about the valves? Okay. So you can have valve disease, right? So if the valves are not working properly, okay, the blood can go backwards, right? And then what does that result in? It can result in heart failure, okay? So valve issues can cause heart failure because the blood is flowing backwards when it's not supposed to. Therefore, you're having that kink problem again. You know, you're kinking the blood vessel. Now you have all of this fluid backing up because you're not able to push the fluid in one direction, which is the point of the heart. Okay, let's go to the next video. Any questions about that? I'm just moving through quickly here. So So while that's pulling up, the third thing is, the way the muscle pumps and squeezes, all muscles in our body squeeze because of a nerve input, okay? So think about like Frankenstein, they give it some electricity and it goes, it's alive, right? Because a muscle squeezes because of electrical input. And in our heart, we have electrical conduction, okay? That moves through, and as the electricity flows through, it causes the heart to squeeze. And with every beat of the heart, you're having a flow of electricity down these highways, okay? These yellow lines that you see here, these are highways of electrical conduction that spread the electricity all through the heart, okay? If you have problems with this electrical conduction, okay, where it's not listening to your body, like let's say that you're running, okay, your heart rate is supposed to go up, that's a good thing. And when you're sitting, your heart rate's supposed to go down. But if there's a problem with the electrical conduction, sometimes the person's just sitting there, the heart rate shoots up, okay? And if the heart is beating too fast, it's not pumping properly, and that can also lead to heart failure. Okay, next thing. So in other words, I'm trying to tell you guys that these terms are very confusing, and I want you to understand that just because somebody has heart failure doesn't mean we know the cause of that heart failure. So we need to ask more questions. Is it an electricity problem? Is it a valve problem? Okay, and then the next thing, is it a blood vessel problem? This is now related to heart attacks. So you see here, there's like blood vessels running through the outside. This is blood that the heart needs to pump. Okay, you can see they're not that big. Okay, that's why people can get heart attacks. Okay, there's small arteries that give important life-saving blood to the entire heart. Okay, and they give it to different regions. You see this artery going to the right side. You see this artery going to the left side. Okay. So they're giving blood to different regions of the heart. If there's a problem here, this is where heart attacks happen, then you can get part of the heart can die, or the heart itself dies and it's not pumping, right? Because there's no blood. And that can also lead to heart failure. Okay, so you can have multiple reasons for which multiple underlying causes for something, that word which is we throw around called heart failure. Okay, any questions about this right now? I'm going to be focusing on this right now. Okay, let's move through. I'm trying to move quickly through right now because I've got like 15 minutes left. Can we move back to the slides and to the next? Okay, so if you could go to the next slide, please, Seth. Okay, so I want you guys to see what heart failure looks like. Can you click on the first link here which says systolic versus diastolic heart failure? You don't need to know the details. Again, you're not in medical school. I don't want you to differentiate between systolic. Like I broke my brain going through that. You don't need to know that right now. But the point is, I want you to understand the concept of when the heart is in failure, it's not pumping. The pump function is weak. The squeeze of the heart is weak. It's not squeezing. Okay? So you can see like the way they're describing it, like the squeeze is not going, so it's like cycling through instead of being pushed in one direction because the pump is not powerful enough, so it's backing up. Okay? Any questions about that? See how the blood is not flowing forward because of that failure. Okay?
So when it's backed up like that, that causes enlarged hearts.
So the enlarged heart causes the fact that it's backed up. Okay, so the fact that it's enlarged and it's not working, a powerful muscle is like strong and small. If it's like loose and like a balloon and it's not moving, it will not squeeze as well, okay? And that can cause blood to flow backwards. Okay, let's just go back to the diagram again. I'm trying to move through this a little bit quickly. See, I'm not babying you guys, right? You know what I mean? I'm giving you guys, this is like real, like I learned this in medical school. Okay, valve failure, let's just go, just a quick example of that. These are all just stuff I just YouTubed, like you can find like a million videos like this. So here there's an example where the valve, instead of closing, it's actually like not closing properly and the blood just backs up. And that also causes heart failure, right? Because the blood is not moving forward in one direction. So they're different causes, right? The muscle is squeezing fine, The muscle is doing its job, right? But the valve is not working, so the symptoms look the same. When you like look at a patient, it's all blacked up blood, the patient is going to have the same symptoms. Okay? Okay, let's pause here for a second. What are the symptoms of heart failure? What's that? So symptoms means what do you feel as a person? Shortness of breath, tiredness, and fluid buildup, right? Again, think of that hose as being kinked, right? If the hose is being kinked, there's fluid building up behind the hose, right? The fluid can't move forward, it builds up. So what is behind the heart? The lungs, so people build up fluid in the lungs, okay? The legs, because of gravity, so all the fluid goes down to the legs, okay? So this is why when people get leg swelling, we take it very seriously. Okay, most of the time people get leg swelling is because of what's called venous insufficiency. The veins, are not doing their job, so water sort of pools there. So most of the time it's probably not a big deal, but we're not assuming that. Okay, we're listening to the lungs. We're trying to make sure there's no fluid anywhere else. You're coming in with leg swelling. I'm listening to your lungs. Why? Because I'm trying to make sure there's no fluid in your lungs to make sure there's no heart failure. Okay. The other symptom is it's something I'm not going to give you medical terms, but it's shortness of breath with laying back against your bed, okay? Like zero pillows, you lay flat against your bed, people get short of breath. They can't lay flat, they have to get up. And a lot of times you'll see people with heart failure like sitting in their couches and sleeping. Why is that? Why is that? Because when you're sitting, all the water goes down to the bottom of your lungs, okay? The water is in the lungs, right? So because it's being backed up by the heart. The water is going down into the lungs, it's settling there. Now you got all these lung width full of air that you can breathe from. So you're not having any problems. But when you try to lay back, okay, try to ever tip a glass and see what happens, right? When you tip a glass, the water level sort of like goes up, right? Like when you're having it straight, it's like this, and as you tip it, it sort of like flattens out. All that water starts rushing up to the top of their lungs, and they cannot lay flat. So again, people say, yeah, I can't lay back. When I can't sleep laying flat, I'm like, oh, okay. And then I'm like, oh, is it heart failure? Like, yeah, my back hurts when I sleep flat. I'm like, okay, that's not heart failure. Okay, so the specificity of the question is important. You have to be short of breath with laying flat, and that is concerning for heart failure. Again, leg swelling can be a lot of things. Leg swelling can just be venous problems, right? The veins aren't working that well. Am I going to get freaked out with everybody with leg swelling? No. So remember, the question has to be important. The question needs to help me differentiate between the different disorders. And the shortness of breath with laying flat helps me do that. That doesn't happen with just vein problems, okay? Okay, let's look at what a heart attack looks like. So this is where those blood vessels, if you could hit the play button, okay? That blood flow doesn't happen because you have plaque buildup. The yellow stuff is plaque buildup. This happens with age, with diet, and all these other things, which I'll talk about in a second. So it's being narrowed. The blood is sort of piling there, and you're not getting blood flow through, okay? And then that black area is the dead heart, okay? The area of the heart is black. That part of the heart is dead now because it's not getting any blood flow there. The heart dies within minutes, okay, from getting a heart attack. When there's zero flow, the heart starts dying within minutes. That's why it becomes an emergency. But as long as there's a little bit of flow, in the beginning you saw there's a little bit of flow, the heart is still getting some blood. So a lot of the tissue is going to remain alive. That's why we want to get to the problem when there's a bunch of plaque buildup, like right now. That's when we want to intervene, before it turns into a full-on heart attack. Now, as you can see, that plaque buildup there, that's not disappearing magically. That's not going to change magically. And it builds up over time. It takes months or years for that to build up, okay? So we have time on our side, and it's slow. It's a progressive disease, and it doesn't get better, right? So when you haven't exercised all winter and you start walking, you're going to get better as you start walking. You'll be like, okay, it's not a heart issue because I'm getting better, right? But if there's plaque buildup, that plaque is not disappearing, right, magically. It's going to stay there. So every time they take that 10th step up their flight of steps, or their heart rate hits a certain rate, at that point, they're not getting that blood. At that point, that chest pain comes every single time. Okay? That's when you know it's a heart issue. Okay. All right, let's go to the next slide here. Any questions about this? Isn't this fun? Isn't this so much fun?
The plaques that you're talking about are really in those vessels that feed the heart
That's
are
right.
not necessarily the ones that feed your brain.
Bingo, bingo, bingo. So what is the problem with the heart? Is the heart doing anything wrong here? No, it's the blood vessels that are feeding the blood to the heart that's a problem. That's why I don't like the term heart attack. The heart isn't doing anything wrong. It's the blood vessels that are a problem. Now, if somebody has plaque buildup in their heart, could they get plaque buildup to the blood flow to their brain? Of course they can, right? There's nothing unique about the heart. Every organ has blood flow. So now, what is a brain attack called? Stroke. Is the brain doing anything wrong? No, right? That's the end result of plaque buildup in the blood vessels going to the brain. It's the same exact disease, just going to a different organ. Okay, so now I want to talk a little bit, I'm going to do this kind of quickly, the value of tests in understanding, is this a heart attack or not? You know, doc, I'm getting chest pain. Okay, let me listen to your heart. Okay, I'm listening to your heart. What does that tell me? What am I listening for? Can I hear the blood flow in the coronary arteries? No. Yeah, I'm listening to how the valves are functioning. Does that tell me anything about the blood flow in those arteries to your heart? It tells me nothing. It tells me absolutely nothing. Okay? So I'm listening to your heart. It's giving me some information. Okay? Again, I'm not trying to poo-poo this, but like I'm trying to get you guys to see that I'm not doing my job if I just listen to your heart and I'm like, okay, everything sounds good. You know? Because I can't hear the blood flow in the arteries, you know? I can't do that, right? I'm not seeing how the heart is squeezing, right? Okay, what if we do an EKG, right? Oh, EKG, okay. Somebody's coming with chest pain, let's do an EKG. Okay, what does that tell us? It tells us the electrical conduction of the heart, right? Remember that electrical flow, okay? And can you have heart disease and your EKG be okay? Can you have a heart attack and your EKG be okay? Yeah. So if you have a normal EKG, does that mean you don't have a heart attack? No. Right? So if somebody's like, yeah, you have chest pain, yeah, I did your EKG, it looks good, all right, take care. That's not necessarily the right thing. I'm not saying they're wrong, you know, it might be the right thing to do. I'm not saying it's not necessarily, okay? And I'll tell you what makes a difference. What about an echocardiogram? Do you guys know what an echocardiogram is? It's an ultrasound of the heart that tells me, just like the pictures, the diagrams you guys were seeing about the squeeze of the heart. This I think we should click on, if you can click on the echocardiogram. Yeah, there you go. And this is what the doctors are seeing, and you can see the squeeze of the heart, okay? Remember, the person is sitting at rest when they get a normal, regular echocardiogram. They're sitting, they're not active, okay? So, yeah, if you could play that for me. So here, what you're seeing up there is normal. Okay, see how nicely the heart is squeezing, right? It's a donut shape. They're slicing the heart this way, okay? So you're not looking at the normal view. You're slicing it like this, like bread, if you lay me flat, and then slice like that. So you're seeing it in a round shape. You can see it squeezing nicely. Here, you're seeing it's not squeezing at all. And that's how you know that's heart failure, right? Because it's not squeezing, the blood starts backing up. Okay, so the point is though, is that yes, this can tell us if there's severe heart failure, if it's like a really bad heart attack that has already happened, I can see that. But if it's a heart attack that I'm worried is going to happen, will I necessarily see it on the echocardiogram? No. Can I see the tiny blood vessels going to the heart on this? No, I cannot. Okay, so I'm seeing how the heart is squeezing and I'm making assumptions about the blood flow, which may be, again, the right assumption. I'm not saying that I ordered echocardiograms when I'm worried about somebody might be having a heart attack or not, but I know the limits of my tests. Anytime we order tests, we must know its limit, and so should you, so you don't get false hope or false, scares, okay? Okay, let's go back to the other thing. So again, because this is happening at rest, remember what I said, at rest you might be getting enough blood, so the heart echocardiogram may be totally normal. So what we do is a stress test sometimes, okay? So we have these different levels of things. Usually we try to get them to run if they can run, and now that heart is beating, it needs more blood, and then we can see the problems with the heart a little bit better, and we can say if there's problems with blood flow to the heart a little bit better. However, it is notorious for being either false positive or false negative. Again, I'm not going to do under the statistical issues, but sometimes it can tell somebody they have heart disease and they don't have heart disease. And sometimes it can tell someone they don't have heart disease and they have heart disease. So these tests are not perfect. The only real gold standard is a catheterization. So if we can click on that. Actually, let's just click on the last thing here. The second one, sorry. Sorry, let's go back to the second one. So I'm just trying to move through a little bit quickly. So what they do is they put a wire, through the wrist or through the groin, and they take that wire all the way up to the heart, and they shoot dye. Okay. When you shoot dye, you can see it like floods the entire artery, and you can see where the arrow's pointing at the top that it's narrowed. Can you see, guys? Can you see how it's like narrowed over there? Okay, that's where they know that there's blockage. That is the only true way to visualize if somebody has heart disease. Only objective, true way to do it. Okay, and then what they do is they put a stent. They go there, they put a stent in there, or they open up the heart, and then they do bypass. Okay, they fix it. So my point is, every test is flawed. What is the problem with this test? Is you're putting a wire into somebody's heart. It's not an easy thing to do. I mean, we do them all the time, and Dr. Wren is great, and doctors are amazing, but you want to minimize your procedures as much as possible, or try to get it early and non-urgently as possible. Every time something is an urgent or emergency, the risk goes up because you're rushing, right? If you do this test, you want to do it where scheduled, everything is stable, your meds are all stable, and then you go in and you do these tests, right? So I gave you guys all these tests, and they're all flawed. So how do we figure out if somebody's having a heart attack? You, right? Your history, the answers to my questions, your answers is more important to me than anything else. Even if the tests are negative, if you're telling me my chest pain is crushing, it's in the middle of my chest, it's worse with activity, it's better with rest, it's not related to my food, it's not related to this, I'm pushing and there's no chest pain, and my EKG is normal, am I still do I care? No. My echo is normal, do I care? No. If my stress test is normal, do I care? No. Right? Because you're telling me what's going on. So this is why I'm doing this talk, is because the tests, which are so expensive and time consuming, they're not as important as your understanding of your own body. Okay? I want you guys to know. And it's hard when I'm seeing the patient, I'm like, okay, is it getting better with activity? Is it worse with activity, better with rest? And they're like, I don't know. Oh my God, I don't know. What am I gonna do next? It's hard, right? Now it's hard for me to figure out what to do next, because I don't know. So I'm gonna be like, okay, let's order an EKG, let's order an echocardiogram, let's order, you know what I mean? I'm gonna do all these things because I'm not getting clear answers. So I would love it if like somebody came in and they're like, yeah, doc, yeah, I saw your talk, and yeah, it's worse with activity, better with rest. When I lay flat, I'm getting da-da-da-da-da-da. I'm like, okay. Boom, appointment's done in 5 minutes, we got our diagnosis, right? So, okay, that was kind of a joke. Hopefully that doesn't happen, but okay. Okay, so there's other things I look at. Okay, can we go back to the slides, please? We're almost done. Sorry, I'm running a little bit behind here. Next slide, sorry. Okay, so yeah, I talked about that. So what do we rely on? Besides your symptoms, I also rely on your risk factors, okay? So if you have a 20-year-old athlete who's coming in with chest pain, I'm not as worried. However, if I have somebody who has high blood pressure, high cholesterol, they have a history of smoking, okay, I did that twice, sorry. They have a family history, my brother's got it, my father's got it, my uncle's got it. I'm sorry, I don't know why I put family history and tobacco use twice, but yeah, so those sort of things tell me that, okay, I need to take, if there's a positive test and you got all the stuff behind you, as far as like 25, 30 year history of smoking, and the stress test is positive, I'm gonna take that stress test more seriously. Okay, there's uncontrolled diabetes, I'm gonna take that stress test more seriously, right? There's a 20-year-old and they're an athlete and their stress test is positive, I'm gonna be like, okay, that's probably not a real true score, okay? And if there's a negative test, right, and they've got all these risk factors, I'm not going to take that negative test as seriously. I'm still going to pursue. Okay? So the background. So again, the history is so important, That office visit is so important because I need this information. And then the next slide, I want to review again before we go because this is so important. This is so crucial. There can be a variety of symptoms, right? You can have chest pain. You can have arm pain like that guy who was who's cleaning window, acid reflux like my other patient, nausea like my other patient, no chest pain like the guy with high blood pressure. And that was his only symptom. He was getting short of breath, sweaty, and high blood pressure with activity. And he thought, okay, I guess it's okay to get sweaty with a little bit of activity. It was mild activity, and his blood pressure was going up. And I was like, okay, whatever this is, I'm gonna trust that I understand the human body. It's getting worse with activity and better with rest. Let me do a stress test. He has enough risk factors here. Okay, he has severe diabetes, okay? and his symptoms are exertional. Okay, so even though he didn't have the actual pain, I still went ahead and I did the test because I trusted the human body is telling me something. Okay, and he had severe heart disease. Okay, so whatever it is, there can be a lot of symptoms. Just remember, worse with activity, better with rest. That's early. When it's happening all the time, then you wait a little bit too long. If it's getting worse with activity and worse with rest, then it's probably people have waited a while. And you might, the other important thing is you might see this in your family members or your friends. What happens when people can't walk anymore? Well, they start like living in their living room. They're not walking upstairs to the bedroom. They're trying to use the bathroom. They're trying to centralize their position. Start asking them some questions. Are you having chest pain? Is it worse with activity, better with rest? Are you having leg swelling? Can you lay flat? Or are you short of breath? If they're answering these questions, go see your doctor. Okay? That's how we save lives in a small community, right? Rural community in Alaska, right? I can't do it. You guys have to do it for me. Okay? So that is my talk. Okay, next slide. These are my two dogs. That's Fergus the Akita, and that's Skana the, I guess he's a mix of many things. We picked him up in Soaring. Any questions?
So maybe a couple. So when someone ends up with a pacemaker, what they're really fixing there is that electrical signal
Bingo.
is out of whack.
Yes.
So it wasn't allowing the beat to
That's
be
right.
where it's supposed to.
That's right.
Okay. And when a person maybe has untreated sleep apnea problems, how does that relate to what's going on with the heart? Because I always hear,
Yes.
it's so hard on your heart if you're not.
Yes, that's right. And so this is an issue that's very dear to me, sleep apnea. But let me just pause for a second. If if there's no blood flow to the electrical conduction of the heart, okay, the electricity, like every other cell, needs blood and oxygen, right? The cells that are making the electricity. So heart attacks can cause arrhythmias, okay? And you can see them on the EKG, okay? The electrical conduction gets disrupted. And a lot of times you can see heart attacks on EKGs. Don't get me wrong. I'm just saying sometimes you may not necessarily, okay? So that's one thing I wanted to point out. So arrhythmias can be related to heart attacks. They can be related to heart failure. Arrhythmias can cause heart failure because the heart is beating so fast the muscle gets weaker and it fails. So all of these things are sort of tied to each other, but you gotta pick out the strands and get very specific with the questions as to really figure out what's going on. What is causing the underlying problem and try to hit that underlying problem. Sleep apnea can cause heart issues because when people are sleeping and they're snoring, they're not getting that oxygen because their airways collapse. Now I have sleep apnea, so I use the CPAP. And my dad has sleep apnea and he didn't get diagnosed, right? So I was like, okay, my dad can get a heart attack, I can get a heart attack. What can I do to avoid it? And I was like, okay, snort like a train. I snort like a train. So I got myself a CPAP, right? And what happens is because the brain is not getting oxygen, it's releasing stress hormones to be like, wake up to your body, to wake you up so you can get oxygen to your brain, right? And when that's happening, you're releasing adrenaline and all these other things, cortisol, stress hormones. What does that do? What does that do to your heart? It makes it beat harder, you can get into arrhythmias, so again, people can have arrhythmias, but you have to figure out what is the underlying cause of that arrhythmia. Is sleep apnea causing that arrhythmia? Is there some heart attack that's causing that arrhythmia? Or heart disease that's causing it? There can be a lot of different things that way. Yes, sir?
So what about specifically as you get older? Is there some kind of correlation? Is just generally getting older and heart disease?
Yeah, I mean, again, our American diets make us more likely to have heart disease. The lack of activity in modern day, because we have cars that we drive everywhere, makes you more likely. And age in general, remember, you're building that plaque up over time. They've done studies where they've looked at teens or young people, 20s and 30s, or maybe not teens, but 20s and 30s who died in automobile crashes, and they do an autopsy and they look at these big vessels, and they can see these droplets of plaque already starting to form in their 20s and 30s, So it's just building up over time, and people end up having severe disease at a certain point. And then the symptoms start, so it's silent, until the heart is I cannot live without this lack of blood, So for a long time, it's getting just enough blood, so it might be silent, but the plaque might be building up for a long time. Yes, sir?
What happens when you get a blockage to a leg artery or an arm artery?
Yeah, so that's the same thing, right? Like, so what happens is, so when you have blockages in like arteries in the leg, it's a leg attack, right? Just like a stroke or a heart attack, right? The blood flow to the leg is gone, right? You have to open that up with stents or surgery as quickly as possible, or that leg may need to go, okay? And the thing is, but you can prevent it again, just like with the other thing. It's muscle, right? Your leg muscles are muscles. So if the person gets definitive pain that is coming all the time, worse with activity, and they sit down and the pain goes away, okay? I'm worried that they have problems with flow to their feet, just like with the heart. Does that make sense? Because the leg muscles are muscles, your heart is a muscle, right? So these people, they walk 100 feet and they start getting leg pain, and they sit down, the pain goes away. Every time they walk 100 feet, they start getting that pain. And now it's becoming 70 feet, and then 50 feet, and then 20 feet. I'm like, okay, let's just go get this before it turns to zero flow. Okay? I've had people where they have zero flow and that foot starts getting white, and you gotta open up the blood flow quickly. Yes, ma'am.
So with when you have a CT done for a calcium scoring test, so what is that telling you, and how reliable is it? Because when my husband had it done, his GP said, "Oh, you're good. Yeah, this is great." A couple years later, no, he was in the cath lab having a coronary artery, angioplasty, 90% blocked.
That's right.
And then, like for me, I had one done, and my doctor told me, "Oh, you have the heart of an 85-year-old woman," and I was, 65, and a jogger, and never had chest pain. So, how reliable are those?
Yeah. So you answered your own question, right? Like, I mean, so it's a test like any other test. It gives you information. So the way I like to think about it is like, you got people who are blindfolded and they're feeling an elephant, and one person feels a trunk, another person feels a tail. It's giving you a bit of information, but you need to put the picture together, right? So you can have someone with perfectly normal coronary artery scoring. So the coronary artery test is like a calcium scoring test is a CT scan where you're measuring the amount of calcium that is in the arteries. First of all, it's not a dynamic test, right? You're not active, you're sitting there getting that scanner. It's a picture. You're not seeing the heart moving like a stress test would, right? So I prefer stress tests because of that. But you can get some good information about if there's calcium buildup or not. But I've had patients where they're like, "Oh, you got tons of calcium, your calcium score is high," and they get rushed to a cath lab and their arteries are totally clean. I've got people who, because it's calcium, right? So sometimes you can have plaque, which is soft and yellow, and there's no calcium, so it reads it as normal, but there may be significant issues. So again, it comes down to your symptoms, right? It comes down to your family history. If I do the calcium score, plus they're smokers, plus they're getting shortness of breath, plus they're not active, plus their cholesterol is like 300. Okay, I'm going to take that stress test more seriously. If they don't do that and their test is, if they have all those problems and the test is normal, I'm looking at it as a piece of information, but I'm not necessarily saying, "Oh yeah, okay." I'm still like, "Okay, do you have any symptoms? Let's talk a little bit about symptoms. Maybe we need to, if you have any of these symptoms, let me know, blah, blah, blah."
Is it measuring the calcium deposits in the coronary
That's right.
arteries? Okay.
Yeah. Yes.
So, quick anecdote and then question. So my dad had a heart attack back in the late 80s, early 90s. He was hospitalized for several days, discharged on the weekend, scheduled for a stress test, I think the Tuesday after, because they weren't doing no stress tests in the hospital on the weekend. So I'm down there, I go shopping, I come back about a half a mile from the house. I look over, here's my dad walking down the sidewalk. "Dad, what are you doing?" "I'm practicing for my stress test." That's what he was thinking.
I love it.
Nobody told
I love
him. My other question is, why do so many people have AFib these
Yeah.
days? I bet there's a half a dozen people in here.
Yeah. This is a long topic of its own. There are many causes for AFib, including sleep apnea. Again, that rhythm is not working. And when it's not working, like so your heart rate is supposed to, when your heart is working normally, it should go up when you're exercising and it should go down when you're resting. If you're exercising, your heart rate is low, that's a problem. If your heart rate is high when you're resting, that's also a problem, right? So it should be doing its job, and it's not necessarily wrong to have a high heart rate. So when the heart goes into AFib, a lot of times the heart is trying to do the right thing, but because it's a little bit older, it's not working as well, it's making a mistake, Usually, if the heart is in AFib, it's because it thinks that it needs to go high because of some other underlying cause underneath. Right? The heart is feeling like I need to go faster to help my body. It doesn't know if you're running a mile or, the heart doesn't know, right? But it senses that there's a need for the heart rate to go faster. And it could be because you're sleeping and you're not getting that oxygen. It could be because of history of alcohol use. It could be because of really bad infections. Because the infection's body's fighting really hard, it needs to beat hard. That's a good thing. You want the heart to pump blood through the body in the middle of like a really bad infection. So sometimes it's trying to do the right thing, and it sort of breaks a little bit, and it just goes out of control, cannot come back down. And your heart also acts like a brake, right? So in AFib, that brake is kind of broken. So it kind of goes like totally out of control. The heart rates are hitting like 170s or 180s. Like it doesn't slow down. It doesn't have the ability to slow down because you're pushing on the brake, and the brake just stopped working. AFib also, secondarily, which I'm not going to go into right now, but it can also increase the risk of stroke separate from this. This builds up within years, right? The clots in AFib form in those chambers. Remember those chambers that's pumping blood? And it has nothing to do with the coronary arteries. I'm not going to get into too much detail, but in one of those chambers is where the clot forms, and it can form that in seconds. Okay? So think about the fact that if I take my blood out, again, you can assume that I'm a healthy guy, I take a bunch of blood out and I put it on a table, what's going to happen to that blood? It's going to clot. Does that mean I have a disease of clotting? No, that's normal. If the blood is not flowing, it can clot. In AFib, it's the atrium is fibrillating. It's not squeezing, so the blood is not moving, and the blood starts to sink, and it can form clots. People with severe heart failure, remember that heart is just not moving, it's not pumping, right? Sometimes they can form clots because of that. And that clot can shoot up and cause strokes. That's why people with atrial fibrillation are on blood thinners.
Could I respectfully ask maybe two questions and we'll call it?
Yes.
So does sleep apnea precede a heart attack, or does heart disease contribute to sleep apnea?
It could be like a bit of both, right? So people who are obese can have sleep apnea, right? So because that obesity can cause the neck to be thicker or the jaw to be thicker, and that obesity also can mean that this person is eating a high, saturated fat diet, which can increase cholesterol and increase the risk of heart attack. On the other hand, the hormones that are released because of the sleep apnea is an independent risk factor for heart attacks and arrhythmias.
Last question? Last question.
I'll ask one more question.
Yes.
So did you mention that you cannot reverse heart disease? I think you categorically said you cannot reverse it.
No. What I'm saying is if a person's not doing anything to intervene, that plaque doesn't magically disappear. I'm trying to get you guys to think in terms of symptoms, So again, when a person is conditioned, that means they're exercising, right? The body gets conditioned, and the shortness of breath or chest pain gets better with activity, over a period of like a month or two. That doesn't happen with plaque buildup because the plaque doesn't just magically disappear. You can intervene on it. You can also take meds to make sure the plaque doesn't build up any more than it has. Somebody has a little bit of plaque buildup. You can take meds. You can change your diet so that it doesn't build up anymore. Or you can go in, put a stent in, do surgery, and all those sort of things to get blood flow around that area.
I'd love to go another 15 minutes, but out of respect for everyone's time, a big hand for Dr. Gowtham.